Welcome everyone who is joining us. We are going to give it a few moments for people to enter from the waiting room before we officially begin. Thanks everyone for joining. We are just giving it a few moments to allow people to enter from the waiting room. So, welcome everyone who is joined for today's webinar on gender responsive monitoring and evaluation for the real world, hosted by the MAGE project, which I will introduce in just a moment. My name is Rosemary Morgan. I'm an associate scientist at the Department of International Health, Johns Hopkins Bloomberg School of Public Health. And in addition to being a panelist today, I have the pleasure of moderating this webinar and introducing our speakers for today. So I'm going to go get us started with the introductions of our speakers, which you can see on the screen here. So today we have joining us Dr. Cholwe Jacobs, who is a lecturer at the Department of Epidemiology and Biostatistics at the School of Public Health in the University of Zambia. Dr. Jacobs is an advocate for gender and health equity, as well as an academic and researcher with over 15 years of experience working with government and different United Nations agencies on gender, sexual, reproductive, maternal, newborn, child, and adolescent health, HIV/AIDS, and non-communicable diseases. She has expertise in gender equity and leadership and health access and gender equity outcomes and utilization of reproductive, maternal, newborn, and adolescent health. Next, we have Dr. Anju Malotra, who is a distinguished professor of the practice in the Department of International Health at the Johns Hopkins University Bloomberg School of Public Health. Dr. Malotra is currently serving as a senior gender and M&E advisor at the Global Financing Facility at the World Bank. She is a recognized global leader on gender equality, reproductive health, and adolescent rights. Her programmatic and research work, as well as teaching, focus on advancing the real-life opportunities and health options for women and girls in low and middle-income countries, and in reshaping financing capacity, research, and measurement systems to propel these efforts to deliver change at scale. And lastly, we have Dr. Asha George, who is a South African Research Chair in Health Systems, Complexity, and Social Change at the University of Western Cape School of Public Health in South Africa. She continues at the Johns Hopkins School of Public Health as an adjunct professor and is a principal visiting fellow at the United Nations University's International Institute of Global Health. She is a qualitative researcher engaged with health systems to advance health and social justice in low and middle income countries. With a gender and rights lens, she focuses on the frontline interface and governance of services, taking into consideration community and health worker perspectives. So welcome our panelists today. So how the webinar is going to work today is I'm going to start us off with a very short presentation and introduction to the MAGE project, but also to gender responsive monitoring and evaluation. What is it and how are we defining it? After this, it'll follow a series of Q&A with the panelists. We'll start with Dr. Anju Malotra, then move on to Dr. Cholwe Jacobs, and Dr. Asha George will serve as a discussant today, providing an overview of key issues and considerations related to gender responsive monitoring and evaluation. So if you have any questions at any time for the panelists, please enter them in the Q&A. So we can moderate that more closely. And we will have time at the end for a Q&A session. So this webinar today is hosted by the MAGE project. So the MAGE project stands for Monitoring and Action for Gender and Equity, and it is a partnership between Johns Hopkins University and the Global Financing Facility for Women, Children, and Adolescents. So that's a GFF for short. A multi-stakeholder global partnership housed at the World Bank that is committed to ensuring all women, children, and adolescents can thrive and survive. So MAGE really aims to advance and strengthen the capacity and execution of gender and equity intentional monitoring and evaluation, and build sustainable systems and capacity for the use of data to improve gender equality, with a focus on reproductive, maternal, newborn, child, and adolescent health and nutrition outcomes for women, children, and adolescents in GFF partner countries and beyond. So the focus of our webinar today, we will be focusing on reproductive, maternal, newborn, child, and adolescent health and nutrition as case studies and examples. But a lot of what we're talking about today is very applicable for different sectors. You can learn more about the MAGE project on our website. Here, you can see the link at the bottom, www.mageproject.org. On the website, we have a gender tools library, so a library where you can search for different gender tools related to different themes and processes. We also have a gender data portal library, which is a list of different gender data portals, so you can go and find relevant gender data for your own work. And we also have our own resources listed on the website, which are going to be added to over the next year or so. Following this webinar today, we are also hosting a workshop on gender responsive approaches for monitoring and evaluation of health programs. If you haven't, or if you're interested and haven't already registered for this, we will include a link in the chat where you can register. So this is from 10:30 to 12 p.m. Eastern Standard Time. And our facilitators are Dr. Anna Kabarchek and Dr. Shatha Elkanabib. So without further ado, let's get into the content of our webinar today. So what is gender responsive M&E, or how are we defining it and approaching it within the MAGE project? So for us, gender responsive M&E intentionally integrates needs, rights, and preferences of individuals, and as well as gender power relations and systems in M&E processes. And what we mean by this is, if you think about a needs, rights, and preferences lens, needs are the individual needs of men, women, and gender minority individuals. A lot of these will be mapped onto essential needs and services. Rights is thinking about what are individual rights, what do people have a right to, and then preferences, what are their individual preferences. Gender power relations and systems look at the ways in which gender manifests as inequities at all levels, including with relation to inequitable access to resources, inequitable roles and practices, inequitable norms and beliefs, and inequitable decision-making power and autonomy. So since gender inequality and power relations systematically disadvantage women and girls, M&E efforts in this space often focus specifically on assessing desired improvements and outcomes for women and girls, particularly in the context of reproductive, maternal, child, and adolescent health. However, that's not to say that it's also very relevant for men and boys and gender minority individuals. And in order to be gender responsive, we are really arguing that programs and interventions need to go beyond just focusing on women and girls by taking into consideration their needs, rights, and preferences, as well as gender power relations and systems. And what we mean by this is an intervention or a program that focuses on women's health, for example, or maternal health or reproductive health, is not necessarily gender responsive. It also needs to take into consideration needs, rights, and preferences, as well as gender power relations and systems. So gender responsive M&E therefore considers gendered systems and assesses a combination of the following here to inform and identify priorities of actions. We've already talked about needs, rights, and preferences. Also thinking about embedded gender inequalities in health and related systems, including gender inequities or barriers that can affect our program or interventions, outcomes, or effectiveness, such as barriers to access and utilization, as well as meaningful participation and representation of target groups within our processes, and inequalities and outcomes between different groups, such as men and women, or poor women and richer women, younger women, older women. So thinking about bringing in that intersectional lens, how does gender intersect with other social stratifiers like age, race, income, rural, like geographical location, for example. The overarching aim of gender responsive M&E, or M&E in general, is really to improve outcomes. But also an important consideration is to prevent unintended negative impact of our projects. So by integrating a gender responsive lens, we can really help to negate any negative impact, unintended consequences, or negative impacts that might occur. This diagram is helpful to try to begin to think about what we mean by gender responsive M&E by asking the question, what are gender responsive data and indicators? So here we have sex specific indicators, sex disaggregated data and indicators, and gender power relations and systems data and indicators. So sex specific data and indicators really focus on one gendered group. So maternal health, access to antenatal care, for example, that would be considered sex-specific data. Sex disaggregated data and indicators compares two or more gendered groups, like men and women, maybe HIV prevention between men and women, for example. And gender power relations and systems data and indicators, these utilize gender frameworks to ask the question, how does gender power relations manifest as inequities at different levels? Where we see the gender responsive data and indicators is in the circle here in the middle, in the dotted line, is in the consideration for needs, rights, and preferences, and gender power relations and systems. So often just having sex-specific indicator like access to ANC is not necessarily enough to be gender responsive, or just disaggregating your data by men and women is not enough to be gender responsive. We have to go a step further by thinking about needs, rights, and preferences and gender power relations and systems. Here is just some examples of these data and indicators that I've mentioned, as well as the descriptions that I've already talked about. So as you can see, we have sex disaggregated indicators, percentage of boys and girls with HIV, percentage of female and male beneficiaries of health insurance would be examples of sex disaggregated indicators. Sex specific, again, only focuses on one gender group. Here we have example of percentage of women receiving antenatal care that meets quality of care standards. We've bolded the part that meets quality of care standards because this goes a step further than just a mere sex-specific indicator by incorporating needs, rights, and preferences. It's not enough just to receive antenatal care, but is that an antenatal care of good quality? Does it meet women's needs, rights, and preferences? And same with percent of family planning facilities offering a woman a choice of at least 3 contraceptive methods. We've bolded offering women a choice because that represents needs, rights, and preferences considerations. It's not enough just to have access to one form of contraception, but having a choice and being able to have autonomy over which method that you want to choose. And then examples of the gender inequality and power relations and systems indicators. These include women's ability to visit healthcare center without asking for permission from a male relative, percent of health facilities managed by female supervisors, or inclusion of maternal health services in health insurance schemes are all examples. Here is a helpful diagram to just think a little bit more about this. So you have your relevant data and indicators, thinking about how you can use sex-specific and sex-desegregated indicators as entry points for gender-responsive indicators. So the sex-specific and desegregated indicators will always relate to people, whereas gender power relations and systems indicators may not relate to people. These may be related to policies or laws, for example. So in order to increase the gender responsiveness, we need to increase incorporate these gender dimensions like needs, rights, and preferences in gender power relations and systems. And at the bottom here, you can see different active approaches also to help us increase this responsiveness, which includes integrating an intersectional lens, meaningful participation, as well as ensuring context-specific indicators which are appropriate and responsive to the context. For more information, you can, all of this that I've talked about today is covered in this brief that is on our website called Gender Responsive M&E for Health Programs, Interventions, and Reforms. And you can find this under the Resources tab on the MAGE website. So with that, I am going to end my presentation and hand it over to Dr. Andrew Malhotra with our first question. So Dr. Malhotra, why is gender responsive M&E important for advancing gender equality in reproductive, maternal, newborn, child, and adolescent health and nutrition outcomes? So we've talked about how you might go about doing it, but why is this lens important?
Thanks, Dr. Morgan. It's a pleasure to be here today, and I think that's a very good fundamental question to start with. I think, first of all, we know that reproductive and maternal health are both fundamental roles that women and girls in particular, biologically and socially, play and has all kinds of implications in their lives, in constraining them or freeing them to live their lives as they choose. And vice versa. We know that there are so many social and economic and gender-related issues that constrain how reproductive, maternal, child health and nutrition outcomes come out. So there's a two-way relationship between gender equality and health outcomes of any kind, frankly, but particularly reproductive and maternal and child health, because reproductive health, reproductive issues are particularly contentious and a foundational reason for having gender inequality in the first place, controlling women's bodies, controlling women's reproductive capabilities, controlling women's sexuality has been a major aspect of gender inequality that has been very difficult to undo. So if we don't take into account, for example, how governments, how policymakers, how a society prioritizes reproductive and maternal health, or how it constrains through policies, how funding, resources, capabilities, then we will not know one of the major reasons for poor outcomes or good outcomes that we are seeing on child survival, on nutrition, on a healthy society in general, and vice versa. If you don't have children being able to live because their mothers died or their mothers don't have access to good health or good care, then you are also going to see all kinds of negative outcomes in society on education, on employment. If young girls are anemic, then they are not going to be able to have babies, healthy babies. They're also not going to do well in school. They're also going to struggle on many other life outcomes. So this two-way relationship tells us a lot about both the kind of successes we can have with the policies and programs that we implement, but also the importance that those programs and policies and resource spending give to the whole issue of achieving gender equality in society.
Great, thank you so much, Andrew. I think you really put it really well why it's important to bring a gender lens into our programming and monitoring and evaluation.
And I
So
would just add, Rosemary, one other point that, the way our systems work right now, we treasure what we measure. And if we're not measuring the gendered aspects of reproductive and maternal health, both in the outcomes and in the determinants, then we're not putting those priorities out up front. And so as we look at major programs or major initiatives like the Global Financing Facilities focus on reproductive, maternal, child health and nutrition, or other, the Global Fund, Gavi, the work on COVID-19, any of those issues, if we don't bring that gender lens into the measurement and the M&E, then those issues are not going to gain importance either.
Yeah, I think we treasure what we measure can be our motto for today, for the webinar. So my follow-up questions for you are, what are some specific examples of how gender responsive M&E can be integrated within reproductive, maternal, child, adolescent health and nutrition, as well as, when you're thinking about some of these examples, what are some of the key considerations or challenges really that we face, particularly as gender specialists and programmers, when integrating gender into M&E within this space?
So I think the first important issue that when we are looking at integrating gender-related M&E into any programmatic initiative or policy reform is that the M&E is about tracking progress on things that we're trying to do. So first, we have to try to do the gender reform or intervention. Many times people just want to slap on gender indicators to a project and measure success, but they were actually not doing anything to achieve those outcomes. So it's not clear why you would want to track something that you weren't even trying to achieve. Now, sometimes there are unintentional consequences, and you can have unintentional negative or positive consequences. So I'll give you an example. Shada and I've done some work, and we found that there are important education initiatives for girls or cash transfer initiatives for girls to go to school, which had an unintentional positive effect on delaying child marriage or reducing child marriage rates. But that's not what those programs were intending to do. That is an unintentional good outcome, but we can also have unintentional negative outcomes, right? Giving women more jobs can also expose them to sexual harassment, and that was not an intended outcome, but that is an unintended negative outcome. But most often when we're spending money in programs, we want to track progress on things that we were intending to make happen. We were putting in some reform to improve maternal health. We were putting in some reform to improve child immunization or nutrition or whatever our goals are. So I think the first issue is that you have to make sure that in your programmatic priorities, there was a gender lens in figuring out what were the gender barriers or systems or other issues that you were trying to change. And I think and then you can have the indicators that are intended to track the progress on that change. And as we have said that this webinar is about the gender measurement for the real world. One of the things that people get overwhelmed by is that we have to address gender in all of these things that we're trying to do, and it becomes almost impossible to implement or prioritize. And one of the ways that we are moving forward in our work, collaboration with GFF, is to prioritize the important things, the big things that the program or the government reform or your intervention is trying to do, and where is the gender issue there. And one of the challenges that has been there is that a lot of the interventions have been focused at women and men and communities. And we try to change, for example, women's decision-making role or men's understanding of the importance of family planning, or we try to change community norms about acceptability of maternal health or family planning. And those are all really good and important things to do. What we don't try enough to do is change the health systems that are catering to women's needs, rights, preferences, and power relations. And so the fact that in so many places across low and middle income countries, there is no running water in a health facility where women are going to deliver babies, or there is no toilet, there is no privacy for her to deliver in. The medicines that are going to be needed when she delivers are not there. That family planning, when she goes to get it, there's a stock out and she doesn't have the choice. So we do need to address the systems and as well as the community and normative issues. And that's where, and if I could have the slide up for GFF, I can just say, here's an example where we have, for the Global Financing Facility, we have tried to prioritize 4 pillar areas where, because the Global Financing Facility is working with governments and using the World Bank loans that the World Bank gives to governments to improve their health expenditure and their health programs, GFF adds gravy to those loans by giving an extra grant as well as technical support. And there, we have the potential for improving 4 sort of key areas where that money can go the extra length to improve gender equality. One is in the quality of care that women get on reproductive and maternal health. So some of the issues that I listed. We can also address healthcare financing. And one of the areas that we are really prioritizing right now is looking at health insurance schemes and whether women have equal access to health insurance scheme, and whether they can use those schemes to not have to pay too much out of pocket expenses or be denied care or forego care. And then another big area, and several of you and Chowe, for example, has been working on this as well, is on the health workforce and the governance. Women are the largest part of the health workforce across the globe, but in different countries, they play different roles, get compensated in different ways, get abused, harassed, have to face a lot of challenges, may not get promoted. I mean, COVID-19 really showed some of the challenges that the female health workforce in particular faced as caregivers. And so much of the work on health is done by women without getting paid at all. So those gender issues need to be addressed. And then data and information system and any kinds of innovations that we're doing also need to take gender into account. And we often don't do that. We don't track, as I said, treasure what we measure. A lot of the health system data do not track enough gender indicators, and we need to move those forward. And not only in tracking them, but then using that data to make decisions and improve things.
Great, thank you, Andrew. So if we can stop sharing the screen. We see we have some questions and comments coming in the chat as well as the Q&A, so do have a look at those, and we'll have time to address them at the end. So thank you for really, providing some additional examples, especially in the context of your work within the Global Financing Facility, but also some key challenges of integrating this gender lens. I would like to move over now to Dr. Cholwe Jacobs. So for really to think about this from a country-specific lens. So my first question for you, Dr. Jacobs, is for you, same as Andrew's question. In your opinion, why is gender responsive M&E important for advancing gender equality and reproductive, maternal, child, adolescent, newborn health, but with a particular attention to the country at the country level?
Okay. Thank you, Dr. Morgan, and good morning. May I begin by saying good morning, good afternoon, evening to everyone all over the world, wherever you're joining us. It's such an honor to be on this panel discussing an important and crucial aspect of health system, and especially that this is towards the global agenda of universal health coverage. Coming back to your question, and maybe before I directly respond to your question, Dr. Morgan, I just want to restate that when we talk about gender inequality in the health system, particularly as it relates to reproductive, maternal, and newborn health, including nutrition, we see that this one is universal. It's pervasive in all contexts, including where I'm based. I'm based in Zambia, by the way. This is where I come from. So this is a universal issue. It's a big problem that all countries are facing. And also, let me just also restate and confirm that evidence shows that the different gender dimensions that you have also stated, including the needs and rights and preferences that you have just outlined, and the power dynamics, decision-making issues, they all influence the health outcomes of particularly women and children. And we also know that women and girls, particularly, represent majority of the population that is served by the services that we are talking about, the RAMCAN services in most of our countries. And so it's very important to note that their needs and preferences are driven by also their gender and reproductive roles, but also the values that we hold in different contexts in different countries. For instance, the preferences that the women may have towards the kind of care they receive, such as respectful care, need to be addressed. But also for the fact that most of the decisions for these particular services we are talking about, reproductive, maternal, newborn, and child health, are rarely made by females themselves who need the services, makes it even worse. And this is why when we talk about gender inequality in the health system for reproductive health services, maternal and newborn, we really need to take care and make sure that we have gender responsive M&E for advancing these services. But also, let me also mention that gender inequitable power imbalances that we see in the health system, really they disadvantage the women and girls in their health outcomes. And this also makes it actually more worse and undermine the progress that is being made towards universal health coverage. And when all this happens, ultimately, we see these inequalities that we note in our countries, particularly in low and middle income countries, where the health outcomes for women and children really are poor. Now, coming back to the question on why we need gender responsive M&E within our country specific context. So I would want to state that with all that I've mentioned, it's important that we identify the gaps. So if we do not have gender responsive M&E, we will not be able to identify these gaps, will not be able to measure the inequalities, which would even be difficult for us to address the challenges that women and girls experience. But also, gender responsive M&E helps us to continuously real-time tracking of progress that is being made. And if we have capacity, if we have the opportunity and the chance to continuously track the progress that is being made, then we will be able in each country to respond in real time to the needs that women and girls do have. But also, before I end, other than just tracking the progress that is being made and identifying the gaps, gender responsive M&E also helps to proactively respond to the challenges, to the gender inequalities issue as it relates to RAMCAN. And if this is in place, definitely this really becomes a success and also a response to the health outcomes for women and their children, including families. Thank you.
Thank you, Cholwe. So thank you again for providing another sort of lens on why a gender lens is important within this work. So similar to the questions that were asked to Anju, so what are some of the efforts being done in your country to integrate gender into M&E for RMNCH and N, as well as some, in your perspective, some of the key considerations or challenges that you have faced?
Thank you. So I must say, Dr. Morgan, at country level, and this is Zambia, I must say substantial efforts are being made. The country is actively, through the Ministry of Health, is actively trying to find ways that the gender-related indicators, this includes the sex-specific and sex disaggregated data, is embedded within the HMIS, but also broadening the indicators, broadening the scope for indicators to include GBV indicators, and most lately, I think we've been thinking of other additional indicators that relate to quality of care for maternal health, neonatal health. But other than the means and the efforts that are being made to integrate these specific indicators to the DHIS2, there's also been a lot of effort being made for stakeholder engagement. We have realized that to ensure that gender is integrated into data and the indicators across the different levels, we ought to keep talking to each other. Different sectors, different levels, different organizations ought to engage to ensure that there's gender mainstreaming across sectors so as to be able to monitor in a more holistic way. So a lot of engagements that are intentional are underway and have been going on, which is a plus. But also at academic and research institution level, greater strides are also being made to ensure that gender lens is used in all research, in most of the research and analysis. I want to reiterate and also mention that Angel raised a pointer that caught my attention, and she said, we treasure what we measure. And if we don't measure gender-related work, then we are more likely to overlook and not address gender-related issues. So within institutions, in academia and research institutions, we've been intentional in trying to ensure that we stimulate students, we stimulate researchers to think about, to have a gender lens in their research work and analysis. And also by going beyond the DHIS2, because as you may know, we are kind of limited in the indicators that we have. So we keep exploring all data sources, including collecting of primary data. For instance, I think the example I'll give for this particular aspect I've touched is the work that we are doing within the institution. So within the country countdown collaboration with the School of Public Health, the Ministry of Health, University of Manitoba, APHRC, as well as GFF and MAGE at Johns Hopkins, we've been exploring all data sources to try and see how we can answer key questions that relate to gender. And I must say that sometimes it's not easy because the data is not available. So it's a kind of data mining process, trying to explore all data sources. And by doing this, we go beyond DHIS2 and pulling all existing data sources, looking at policy-related data sources, looking at human resource-related. All this is in efforts to try and use a gender lens within our analysis, within our work. But also I want to say that within the Women in Global Health, we've been engaging with stakeholders, including the Ministry of Health, in trying to explore and apply the gender lens within the health system. So currently, with support from Gavi and CDC, we are putting up a proposal to assess the safety concerns relating to violence and harassment among healthcare providers, majority of who are females. And this evidence, we think that it's crucial to the health system strengthening at country level, but it also stimulates our thinking towards ensuring that we have as many indicators as possible within our M&E. But I also want to give another example that for work that we are almost starting with MAGE, Johns Hopkins, yourself, Dr. Morgan, where we're trying to look at women leadership and governance in the health system, as well as additional work that we've been trying to look at. So I think these efforts are crucial because they keep us awake and also they stimulate this interest and the treasure so that we continue measuring gender-related indicators. But maybe coming to the second question where you asked about the key considerations or challenges. Allow me to probably touch on the challenges. In as much as these efforts are being made to ensure a gender-responsive M&E, routinely monitoring and real-time, I must say that there are quite some challenges in this process because the data itself is not available. As I've just stated, that you need to keep exploring to look out for this data. And I look forward to a time where we'll be equipped enough to measure, to have a gender lens in our analysis and in our research. And I must say that I think there's light at the end of the tunnel because the processes that we do really helps us to explore more widely. So the data itself can be challenging to measure gender-related, to have a gender lens on our research and in our work. But also, I think it's an issue of a buy-in from various data platforms and tools and instruments. You have to pull different data sources. And also you must have a buy-in because sometimes this data is sitting in different platforms. So this is a specific challenge that we have even at country level. But in ending, allow me to talk about the other crucial, one of the big challenges is resources. So this includes technical resources like expertise to really bring in this idea and the lens of gender within the work that we do, but also financial resources. As you know, we need resources to sit and to think through some of these aspects that we think about as relates to gender. And so these are some of the challenges that we really face, even as we are enthusiastic about gender lens in our work, in our analysis. So I'll end there, Dr. Morgan, and thank you so much.
Great, thank you so much. Thank you for providing some examples from your experience at the country level in Zambia, as well as some real challenges that you have faced. I'd like to now hand it over to Dr. Asha George, who's going to provide some reflections on on the discussion today and bring us home. So over to you, Dr. George.
Thank you. Thank you, everyone. It's a delight to be here with you. And I think we've had three great presenters, and it was fantastic to present that policy brief by MAGE, where Rosemary unpacked some of the work that they are doing at the GFF. I think there are three key points that I pulled away with, and maybe starting first with what Cho-Wei Jacobs spoke about is why this is important. And she spoke about how gender is a universal experience. It really defines, it's the core of how we make sense of who we are, what we do in the world, how we're valued, what kind of access we have to resources, how we're recognized and respected. And that has huge implications for how our ability to navigate health programs as individuals, but also which health programs are funded and supported in health systems. And I think that that's why measuring what was said is so important, because some of these key things are not currently measured or measured well if we're aiming to have transformative impact. And I've worked in the health sector for a long time, so there is, I think, these resources help to, and presentations have really driven home the point that we can work on women's health. And certainly the statistics, we're really seeing a stagnation in progress in maternal and child health. And yes, maternal mortality, the data is very difficult to ascertain trends, but there is there's an overall sense and a call to action, because the declines have slowed down considerably. And a key part of that is we're not addressing the underlying power dimensions, the underlying inequities. You can get a woman to have at one A&C visit, but will she complete all 4? Will she understand the information? Will the mother-in-law allow her to go back? What happens when she goes back home and her husband or the family structure doesn't support her in the next few steps? So all of these, it sort of pushes us to understand much more the social context that really shapes healthcare seeking behavior, but also the role of health workers in delivering services, which are primarily women at the front lines. So Anju spoke about this. It's really at the heart. What we measure and how we look to improve programs is the reason why this is important is because it can have a catalytic effect in improving our programs, but also many of our programs may unintentionally have negative effects, and which we are not even conscious of. And that was mentioned, the way we roll out digital health programs. Who has access to that? Who has access to the digital phones? In what ways? It might be that male partners have the phone and are reading the messages that are meant to be going to women beneficiaries. So we have to be more cognizant of not just how we can have impact, but also how our programs could have negative impacts. And that's why monitoring is so critical. I had a few, I know we're running out of time, but I had a few comments. I think the resources go a long way in terms of improving our language and understanding. So identifying what are gender-specific indicators, really moving us beyond sex disaggregated indicators to really the whole world, where they've presented in terms of needs, preferences, rights, looking at health systems responses. So there's a lot in there in the resources. I find that a lot of times in the health sector, we're often primarily working at disaggregating health indicators. And I would just encourage colleagues, there are a few demographers, there's the world of gender equality is much broader than what we have in health. And we need to begin to conceptualize how we think about gender equality and its impact on health. And there are many other frameworks and sources of data. So yes, we need to work in the health sector, but I think we need to be more literate in terms of other data sources. And particularly if we want to look at gender equality and women's empowerment. It's a huge field. Many of you are cognizant of this, but it's helpful to think about agency, how our programs are impacting on agency, relational gender power relations, how our programs are changing, how families, partners, couples interface with the program, and then structural inequalities. And I think if we can begin, that's a little bit, it's there in the MAGE resources, but there are all these different ways of thinking about gender. So I always think of agency, relations, gender relations, and structural power. And then once we get to conceptualizing what we want to measure, what we measure is just as important as how we measure. So a program that I work with here, we realize that the data collectors, they have 7 forms in following up with adolescents in disadvantaged communities here in Cape Town. And we realized we were spending all this time on the forms, and there was a lot of interesting things there to change in terms of gender mainstreaming them. But then we realized that they are collecting this information in a public space, and they have 10 minutes to establish rapport, and go through these forms, ask very sensitive questions about sexuality and many other things. And we realized it really had an impact. That's why the quality of the data. So how we collect is just as important as what we collect. And I just want to leave it at that. There were many other insights, including the program, the data collectors had questions around trans adolescents, but because they knew that the program didn't do anything with that data, they often skipped those questions. So there are various levels at which your M&E system, it's reviewing what data is there, but the whole ecology of that data system, how it's collected and how it's processed and analyzed is just as important. Thanks very much. I look forward to your questions. I know there are a few in the chat. Over to you to steer us through this in the remaining time. Thanks.
Thank you so much, Asha, for those reflections and kind of really bringing everything together and sort of adding even more complexity to the discussion today, which is very much important. So we have a few minutes. We have about 9-10 minutes left for Q&A, and we have a few questions have been coming in the chat, as well as some, or in the Q&A function, as well as some in the chat. One of the questions I'll just take a moment to address quickly was about, in the framework that we presented, we referred to gender, like we called the indicators sex specific and sex desegregated and not use gender. And this was actually had a lot of conversation and back and forth about this. The comment says, like, from my understanding is that when the outcome is a social concept, such as food security, not a biological concept, it is better to use gender desegregated specific, and using the term sex can be misleading. And that's absolutely right, that sex and gender are often very much conflated. And we did go back and forth about this. And at one point had sex/gender specific, at one point had sex specific and gender specific. And because there is a lack of coherency within the field about a lot of the terms that we used, we chose to stick with the recognized terms that have been used within the field, especially within the monitoring and evaluation space, around sex desegregated specifically. Sex specific a little less so, but sex desegregated, and then integrating the needs, rights, and preferences. So this was a big conversation that we did have, and in some cases the indicators you use will be more gender specific, and in some cases more sex specific or gender desegregated, sex desegregated, depending on what you're looking for, you're looking at. So I'm going to address some of the other questions here. One question from Anne Rogers is, Anne is asking about if we have any suggestions for gender responsive indicators that are not specifically outcome indicators. So for projects that measure outcomes intermediately, are there suggestions for how to make process or output indicators gender responsive? And maybe Andrew, can I hand this question over to you?
Yeah, that's a really good question. And I think that's where our energy is going right now, because often we can say, okay, ANC with quality of care, effective ANC, where all the right things done when was the standard of care met, but that's still an outcome indicator. Where we need to focus our attention is at the lower level, usually at the district level, the things that are getting measured. And I think Asha gave some really good examples of how we do need to prioritize and streamline the ways in which we do things, because often we think that we're just going to give more indicators for providers and other people working in facilities that are already understaffed, that have so much to do, and how much energy should they be spending on providing the care that they're supposed to provide versus gathering the data. So, typically some of the output and process indicators that we are looking at, a few I mentioned, for example, facility readiness related output indicators. Were there any stockouts of medicines in the last 3 months that were essential for maternal care or for contraceptives, for example? Was there a female provider present every day that deliveries were done? If that is an important issue in a country, that the provider doing the delivery be female, which many of the countries where GFF works, for example, this is an important. Women are not going to go for delivery to a male provider, for example. Or you have indicators, as I said, just to the issue of, was there emergency transport available to take a woman who needed a cesarean to a facility that she's being referred to, because otherwise she's almost certainly going to die. So there are many such indicators, but we also need to prioritize. And as I said, even indicators such as for child-related indicators, depending on countries' norms and preferences, babies will be taken, neonates will be taken for more care or for getting emergency nutritional care, depending on their male or female, because in some countries, well, many countries, males are more valued, and we see indicators in neonate units of how many girls versus boys. So actually, in some cases, the sex disaggregation really does matter, because that is what is important in that country. So tracking some of those ground level indicators is really key. And what I find in many countries where we work is that at the facility, or the provider, who's the community health worker who's going, they are actually recording some of these quality of care or sex disaggregation or other indicators. But when the data get aggregated up to the district level, where they're getting data from all the facilities, they lose many of these nuances of the quality of care or the disaggregation. They're feeding into the computer system things that are not that don't have that nuance, and that's where a lot of the legwork needs to be done. So I think that summing up some of what Asha and Chube were saying is the real test of making sure that at the ground level, the gender intervention and measurement are happening. Was money allocated? Were the people empowered? And was there political push behind it? To me, those are the three key aspects that are going to make these things happen. And then some of the logistics of how that happened, how many forms there are to fill out, how streamlined, how much support the providers are getting, is going to be key in actually moving the train forward.
Great, thanks, Anju. Choi, I would like to direct the next question to you. From the question is from Deborah McSmith, and they ask, as we emphasize the need for more gender-specific data and ask countries to introduce new and additional indicators to track, that we need to think about how to build the capacity and resources to support those additional data-related tasks. What is happening in countries towards this end? And then we are limited on time, so if we just to keep responses brief, and then we can address one more question.
No, thank you, Deborah. That's a very good question. On this panel discussion, of course, we have emphasized the need to to think about additional indicators, which we think they're lacking, and we think we can explore other sources. But as we do this, you are right, we need to be asking ourselves, how can this be possible? And how can countries be part of this process? So Andrew just mentioned the political will. So the political will is the beginning. Yeah, when the leaders see the need for this, they are more likely to support these processes. And so what we are doing at country level, efforts are being made. We are not yet there. Through the Women in Global Health, we have been advocating. We advocate for need for a gender lens in leadership, in service delivery. And to do this, we need to draw the attention of our leaders. And to do this well, there's need for evidence generation. So we've been trying to generate evidence to really show that there's need for capacity, there's need for resources to make this happen. But regarding capacity building, this is a very important point, because this really needs to be taken care of. And when resources are put in, we're more likely to build a bigger army, a bigger resource for analysis and using the gender lens. So not much, but advocacy is ongoing, and also trying to look out for grants and opportunities to seek for resources, so that the capacity is ongoing and is built, so that we have a bigger pool of people that are able to analyze and have a gender lens in the health system, particularly in the reproductive and maternal health.
Thanks, Troy. You're absolutely right. And capacity building is so important and to also identify the importance and relevance of these issues. So our last question today, Ash, I'd like to direct this over to you. And it's about how often women, gender is equated with women. And we are, a lot of our examples today have focused on women and girls because of, the substantial inequalities that they face in the RMNCH space. And this perception, the equation that gender equals women really exists everywhere, this perception. And it gets translated into different policy implementation levels. And this is a question from Ramya. And so she asked, how could M&E address this?
So I think it's particularly relevant in the sexual and reproductive health world, because women bear the burden of most of sexual and reproductive health and maternal health. So we need to be conscious of that. But we also, so there's an issue of priorities. What is the foundation, and then how do we build further from that? So if we understand that as the foundation, it's still critical to think about gender power relations. And so one step is understanding what are the health outcomes and whose health outcomes you're trying to address. And in sexual and reproductive health, that's often the biggest burden is still around women and girls. In Africa, HIV amongst young girls is so much higher than amongst young boys. So I think you have to look in each context, which is the population that has the biggest burden, and it'll depending on the health condition. But then the next layer is really to look at, in that context, what are the gender power relations? And I was struck here in South Africa, we're looking at teenage pregnancy. We asked the girls an extensive module on teenage motherhood. And then we also asked young boys, but there were no follow-up questions about fatherhood. And, who's getting these girls pregnant? So it is helpful when we want to understand and have an impact on the social dynamics, is to really look at how do those gender power relations influence the health outcomes, and then begin to think of who are the stakeholders, who are the power, in that social context that influence behavior, and how do we address them? It might be male partners, it might be mother-in-laws in India and many other places. It's not just the binary, but it's who are the other power holders, and how do we address their roles in health programs. So for me, it's more than just boys and girls or trans, it's understanding the power system in that society and how does that interface with our programs. I hope that helps.
Yes, thank you, Asha. And thank you everyone for joining us today. We are just a few minutes over, so need to wrap up. So thank you so much to Anju, to Cholwe, to Asha for joining us today. And thank you to everyone in the audience. We have recorded the session today and we'll share the recording with everyone who registered, and we'll likely put it up on the MAGE website. We've included a link to the MAGE website for you can access more resources. And I see some more resources coming in as well that might be of interest to you. So thank you everyone who joined us today, and hopefully we'll see some of you at the workshop in half an hour. All right, bye.
Bye.